and intrauterine fetal growth restriction management. And help me, Grant. It's not moving. Okay. Yeah. Okay, sorry about that. So pre-eclampsia is a common condition in our setting, and worldwide, everyone agrees that it causes significant maternal and perinatal morbidity. In literature, the incidence is recorded as 5 to 10% in the Caucasian countries, but in a study that was done locally by Professor Ngwenya, he noted an incidence of 1.5% for severe preeclampsia at Mupilo Hospital in 2016. So this means preeclampsia is affecting about 10 to 15 women, about 10 to 15 for every 100 women who deliver at Mupilo Hospital. So this shows us that we have a high burden of preeclampsia in our setting. It is also agreed on that hypertensive disorders are the third leading cause of maternal mortality in Africa and also in our setting. For the perinatal outcomes, Professor Ngwenya assessed the outcomes in about 127 women who had severe preeclampsia at Mupilo Hospital in 2016. He noted that of the 127 women who delivered during that year and had a diagnosis of severe preeclampsia, about 75% of the women ended up going home without a baby, because most of them, they had early neonatal death. The babies ended up having early neonatal death, and about 45.9% of the pregnancies resulted in a stillbirth before term. So this was noted mostly in women who had early onset preeclampsia, that is, women who developed preeclampsia before 32 weeks. So pregnancies complicated by preeclampsia or fetal growth restriction have defective maternal vascular responses to placentation. And this is to say there is failure of the second wave of trophoblastic migration, which leads to reduced amount and depth of myometrial trophoblastic invasion. As shown in the diagram on the right there, this is a normal spiral artery. We can see that it's spiral in its caliber. And we can see the trophoblastic cells trying to invade the myometria. We can see the progress in the invasion of the spiral artery in this second vessel here. We see these trophoblastic cells are embedding themselves within the wall of the spiral artery, and that's disturbing the spiral nature of the original spiral artery. And in the end, we end up having like a funnel-shaped vessel, and we are trying to move from the high resistance, which is the normal status of the normal artery, of the normal spiral artery, to the low resistance, high capacitance that we then see after the second wave of trophoblastic invasion. So if this fails, if the second wave of the trophoblastic invasion, which should occur between 11 to 16 or 18 weeks, if it fails, we end up having placental hypoxia and ischemia, and this can actually be measured using biophysical Doppler studies of the mother in the fetus. So what is the role of Doppler studies in pre-eclampsia and fetal growth restriction? We can use Doppler studies to predict pre-eclampsia, to detect abnormalities in the, to detect progression of pre-eclampsia disease in the fetus, to monitor pre-eclampsia and intrauterine fetal growth restriction, as well as to make decisions concerning delivery, administration of antenatal steroids, magnesium sulfate, and it can also help us to come up with strategies for monitoring the preeclampsia and intrauterine fetal growth restriction. So these 5 things are the main roles of Doppler studies in preeclampsia and fetal growth restriction pregnancies. So we can predict in the first trimester around 12 weeks by making use of the uterine artery Doppler studies. And then we can detect fetal growth restriction also by using the Doppler studies. We can actually monitor progression and evolution of the Doppler studies. And we can also make decisions concerning the delivery, mode of delivery, and monitoring of such pregnancies. So for the uterine artery Doppler studies, I've mentioned earlier on that we can actually check the we can actually check the maternal hemodynamic status or maternal adaptation to placentation by studying the uterine artery Dopplers. So for the uterine artery Dopplers, we look at the pulsatility index and the early diastolic phase, which is this phase. So this is systolic phase, this is diastolic phase, and we are looking at the end, at the early diastolic phase here in the pulsatility index. So those things, they can actually tell us about the maternal vascular response to placentation. And if the pulsatility index and the resistive indices are high, and there's persistence or presence of an early diastolic notch within the waveform of the uterine artery, this is associated with increased risk of preeclampsia and adverse pregnancy outcomes like miscarriage and fetal growth restriction. So in this image here, we can see that there's systolic, the height of the systolic wave has increased as compared to what it is in the first diagram. We can also see that there is now a bump in between the systolic waves. So this means that there is an early diastolic notch that is coming in between the systolic phases. And this confirms that there is persistence or presence of an early diastolic notch, and this pregnancy has not adapted well to placentation. So if we assess a woman around 12 weeks, and we note that the mean uterine artery pulsatility indices are high in both uterine arteries, we measure both uterine arteries, the left and the right, then we calculate the mean pulsatility index, sorry. So if it's high and there is a diastolic notch, then that is confirming that the woman has not adapted well to placentation, and we should prescribe aspirin 150 milligrams once daily. And that will sort of help to prevent adverse pregnancy outcomes like stillbirths and preeclampsia. For the umbilical artery Doppler studies, So what happens in the umbilical artery? Normally, the pulsatility index should fall with gestational age, and the mean pulsatility index should then stabilize after 30 weeks. So if there's a pre-eclampsia and or fetal growth restriction, we can end up having an elevated pulsatility index and the resistive index as well. So when we note these things, when we note a high PI and a high resistive index, then that pregnancy is at a more increased risk of getting adverse fetal outcomes. So for us to be able to see that this is normal and now this is abnormal, we should know the normal, and we should also know what to do when we get a result that is showing abnormal Dopplers and at this point abnormal results for the umbilical Doppler studies. So in the image that is in the left corner here, we are seeing the normal waveform for the umbilical artery. And we can see that the waveforms are sort of, the height is the same, and there is good diastolic flow throughout the diastolic phase. There is good flow there, and it looks like a sawtooth. So all the time, the waveform of the umbilical artery should look like this. I'm not sure if the images are clear, Dr. Verenga. Dr. Verenga? Dr.
Yes, they
Chamnyonga?
are. Yes, they are. They are very clear. Thank you.
Okay, so this one is the normal. I said it should look like a sawtooth. Why? Because we have high flow during systole and also a good flow during the diastolic phase, all the way from the early diastolic to the end diastolic phase. And it should always look like this throughout the gestational period. When it starts looking like this, we have taller waves and sort of deeper gaps between the waves, like what is shown in this image. There will be high pulsatility index and reduced end diastolic flow. So this is the first abnormality that we can see. And then from the high pulsatility index, reduced end diastolic flow, we then get absent end diastolic flow. You can also see that the waves are still tall, but there is no flow during the diastolic phase. And when it's looking like this, we say there's absent end diastolic flow. In the last image here, we can see that there is reversal of flow. We can see a short wave that is coming in between the taller waveforms, and it's underneath the zero line here. So when it's like this, we say there is reversal of flow. So this is sort of the normal evolution of the Doppler studies in a woman with pre-eclampsia and early onset fetal growth restriction. It's not like all the women or all the babies are going to follow through the sequence of normal PI, normal end diastolic flow to high PI, reduced end diastolic flow to absent and then reversed. Most of the babies are going to go like that, but some of the babies may not follow through this sequence. But this is the normal sequence that follow. So for late onset, for late onset, we can have a normal umbilical artery waveform and an abnormal, and that baby's life can be in danger, just as the baby who has reversed end diastolic flow. So we should note that for late onset, the evolution of the Doppler studies is sort of different. even with a normal umbilical artery, we can have an abnormal midcerebral artery, and that baby can end up dying in utero. So what is the significance of these abnormal Doppler studies? So of note is that when there is absent and reversal of end diastolic flow in the umbilical artery, the acid-base balance has become disturbed, and that the baby who has absent or reversal of end diastolic flow most likely has acidosis. And in those babies, in studies that were done, it was noted that they are at a more increased risk of getting severe morbidity and mortality before delivery and after. So before delivery, if we have absent and or reversal of end diastolic flow, that baby is at a more increased risk of becoming stillborn. If that baby is then delivered, the baby also has an increased risk of getting all the severe neonatal conditions that we know, like the pulmonary dysplasia, necrotizing enterocolitis, intraventricular hemorrhage, and also early neonatal death. So if you find a result that is showing absent end diastolic flow, you need to think otherwise. You should not keep that patient. It means you should take action, because that baby is at an increased risk of dying in utero. And even if you go ahead and deliver, it's a baby who needs to be attended to by a neonatologist on delivery, because the risk of severe morbidity and mortality in the early neonatal period remains high. So moving on to the midcerebral artery. The midcerebral artery naturally has a high PI. So the PI increases to a maximum and the maximum is all the way to 10. It has sort of low sorry about that. It has low diastolic flow. As you can see, this image is showing a normal midcerebral artery. So we can see these toe waves that are showing that there is high PI, and we see that the waves, the waveform during the diastolic phase is sort of flat, and at times, especially before 30 weeks, there is no end diastolic flow. So when we have a patient with pre-eclampsia, or fetal growth restriction, we know that there is hypoxia. And when there is chronic hypoxia, there will be what we refer to as the brain sparing phenomenon. So when that happens, there's redistribution of blood to the brain and other vital organs. So we can actually measure and confirm that there is the brain sparing effect or redistribution using the midcerebral artery. So since we know that normally there is a high hostility index and low end diastolic flow, when we then measure for a patient with chronic hypoxia, we can see that the hostility index becomes lower and lower. And when it becomes less than the 5th centile, we then say it's abnormal, we then say it's low. And we can see, as shown in this image, that as the pulsatility index gets lower and lower, the end diastolic flow increases. If you compare the two images, this one and this one, we can see that the waves in this image are shorter, and the end diastolic flow has increased. There's now a bump there, a bump there, a bump there, which is actually showing that the end diastolic flow has increased. So this is just to show us that there is chronic hypoxia, and the baby is trying to compensate by sending blood to the more vital organs. And obviously that tells us that the baby is unwell. So the image that is at the bottom here is the mid-cerebral artery for this patient, for the patient who had reversed end diastolic flow. And this is actually progression of the same patient from high to absent to reversed. And this image of a normal umbilical artery here, this one is the mid-cerebral image of the same patient, which is actually telling us that this baby is okay. And this one is progressively getting worse and worse. So moving on to the ductus venosus. The ductus venosus, we all know that it's a shunt that sends blood, that sort of, it shunts blood from the liver and straight to the heart via the inferior vena cava, and sometimes directly into the right side of the heart. So there's always a high flow in the ductus venosus. We can see here in this image that is showing a waveform of that is showing the normal waveform for the ductus venosus. So we can see that there is good flow. It looks like an M. There is good flow in the systolic phase, in the diastolic phase, and during this period of atrial systole. There is always good flow in the ductus venosus because it's shunting blood. It's a very short vessel that's shunting blood from the portal sinus to the inferior vena cava or the heart. So what is known from the basic science is that the 95th center, the PI for veins, which is the PIV for the ductus venosus, falls from 20 weeks to term. And then if we then measure and get values that are above the 95th center for gestational age, those values should be regarded as abnormal. So if I get pregnant today, as the pregnancy advances, the ductus venosus PIV, pulsatility index, should fall from 20 weeks until term. The 95th center should keep on falling. So if I get a scan and I have a ductus venosus PI that is greater than the 95th center, that value will be abnormal. So what happens is here we have a normal waveform with good flow throughout the waveform. In this one, we can see that the M shape is more clear, and the M shape is clearer, sorry, and there's no flow in between the waves. Or maybe let's start with this one. You can see that in this one, the aim is clearer and there's a deeper space between the waves, which is showing us that the PI has increased and the A wave, the atrial systolic phase here, is actually decreased. And we can see worsening of the ductus venosus Doppler in this image when we have no flow at all in between the waves, and this is absent A wave. We can see in this patient that we now have a shorter wave that is coming underneath the line and is showing us that there is reversal of the A wave. So this image, we took it from the same patient who had the abnormal mid-cerebral artery and reversal of flow in the umbilical artery. So the ductus venosus allows detection of further deterioration in the Doppler studies, and it actually identifies the preterm growth restricted fetus at greatest risk of dying in utero. The absence or reversal of the atrial systolic forward flow, which I told you that we call it the A wave, is associated with severe perinatal morbidity, intrauterine fetal demise, and significant postnatal morbidity. So when we have absent or reversal of the A wave, if we find a result that is showing this, it means that that baby is very sick and has cardiac failure. So those babies are associated with significant perinatal morbidity. They are at a more increased risk of being stillborn, and even if we deliver them, they need the immediate attention of the neonatologist because they have significant postnatal morbidity, and they can also die in the early neonatal period. So when we see patients with pre-eclampsia, fetal growth restriction, and abnormal Doppler studies, there are some factors that we should consider before we decide on what we are going to do for that patient. So we need to consider the fetal condition and the maternal condition as well. For the fetal condition, we should review the Doppler results, and if at all we are not sure of how to proceed with the results that we have, we should always consult. We should consult our consultants or even the consultants from the fetal medicine department. Even if when we are not on call, we are always there to assist whoever needs help. For the maternal condition, sometimes we see patients who come into the fetal medicine unit. Those patients will be very sick, they are grossly swollen, they can hardly breathe, and some of them won't be having the basic results, the full blood count, urea and electrolytes, liver function tests. So let's always check the maternal condition and exclude target organ damage. We should always consider the gestational age as well, because it is a very, very important prognostic factor. And obviously, the gestational age will give us an idea of the estimated fetal weight. So we have our patient, we have the Doppler result. At that point, we should always consider if delivery is recommended. If delivery has been recommended, we should always consider the timelines. So say it's a patient who's having a reversal of flow in the umbilical artery Dopplers, or an absent A wave or reversal of the A wave in the ductus venosus. Those patients should be delivered within 12 hours, at most 24 hours. If we leave them to stay in the ward for days, even 2 days to a week or so, we are going to lose those babies. And we've actually seen that in the fetal medicine unit. Most of the patients we say for immediate delivery, and then we see them 3 days down the line with an IUFD, and it is really sad. Once we make the decision to deliver the patient, we should always inform the neonatology team. At Harare Hospital and Pari, we do have neonatologists who are willing to attend the deliveries and are always there to assist with everything that is needed to make sure that we deliver the baby and hand them over straight to the neonatologist, not to the midwife. Before delivery, we should also counsel the patients, because these patients are going to deliver, if it's early onset fetal growth restriction, they are going to deliver very small babies who have been failing to grow all along, so they'll be very small and sick, especially if there is reversal of flow in the umbilical artery and the ductus venosus. So I've already mentioned that these babies are at an increased risk of having severe postnatal morbidity. So they are going to be admitted to the NICU, and at the NICU, they'll be very sick and they may actually die. So we should cancel them on the most likely poor outcome, and also on the fact that the baby is small and will need some time in the nursery as well. On the mode of delivery, we should always weigh the pros and cons for induction of labor and cesarean section for an individual patient. It doesn't follow that a patient with this he should deliver like that, but let's individualize the approach, and let's always consult the consultant from our units, and also a consultant from the fetal medicine unit. If we then decide to allow the patient to deliver vaginally, these patients need monitoring, and if it's possible, they need CTG monitoring. And at Harare Hospital, we now have a CTG, and if we are able, and if it's available, these are the patients who should have CTG monitoring during labor. If a patient needs all these and it's not available, the best thing will be to deliver that patient by cesarean section. This is the end of my presentation. I would like to acknowledge the fetal medicine team, and thank you for listening.
Thank you, Dr. Ndagurwa, for such a lovely presentation. Unfortunately, we don't have much time. We're left with about 13 minutes. So what we'll do is we'll allow Mr. Zanga to present first, then we'll have a discussion after his presentation. Unless if we have burning questions, I think we'll allow Mr. Zanga to present now, then ask later. Mr. Zanga.
Hello, can you hear me?
Yes, we can hear you, Mr. Zanga.
Okay, can you allow me
Please
to share the screen?
Okay.
Allow me to share the screen. Can you see my screen?
Yes, we can see your screen, Mr. Zanga.
Okay.
You can go
All
ahead.
right. So I think my colleague shared the majority of this, so I'll go straight to the outcomes slides. This is the same presentation which was done during the meeting last Saturday. So I'll go straight to this from this slide. This is preliminary data of follow-ups which we are doing on the patients which would have passed through the fetal medicine unit, and most of them will be having some abnormal ultrasound findings. So for the patients who had fetuses who had absent or reversed end-diastolic flow, those with absent were 35, and those with reversed end-diastolic flow were 18, making them a total of 48. But out of the 48, we managed to get outcomes for 17 so far. Follow-ups are still in progress. Some numbers were unreachable, and some didn't have the data readily available. So I will discuss on the 17 which we managed to get the outcomes. So from these 17 babies who had absent or reversed end-diastolic flow in the umbilical artery, the outcomes were as follows. 8 of them are alive, but 9 of them demised. And those who demised, 1 was a fresh stillbirth, 5 were macerated stillbirths, and 3 were early neonatal demises. So for those which were alive, we managed to use the Doppler evaluation as was being described, because Doppler is a very good marker of describing the condition of the baby in utero. So we managed to buy some time whilst closely monitoring the Dopplers, either 3 days or weekly. So for the maximum time we managed to buy was 5 weeks, and some we managed to get 1 week, which resulted in the birth weights of all those who are still alive to be more than the 1,000 gram threshold. And they were admitted into the neonatal units with durations ranging from 4 days to a month. And of them had to be ventilated because of respiratory distress syndrome. Then for those who didn't make it, I think the part which was being said earlier on, so when we assess the Dopplers, and we would have pushed the estimated fetal weight to above the 1,000 gram point, and we see that the Dopplers have deteriorated. So the ductus venosus, if we see that the ductus venosus now has absence of flow during the atrial wave, or it has reversal of flow, then we know that the baby is at great risk of demising in the next 48 or in the next short while. So we usually, once we have reached that stage, we recommend delivery. So you can see that here on these first 5, all of them had reached the 1,000 gram mark. But unfortunately, most of them ended up delivering spontaneously by normal vaginal delivery, implying that they were not taken to theater and they ended up undergoing spontaneous delivery to give us the macerated stillbirth. And another important or learning point, you can look at all of them, all 5 of them were pre-eclamptic, and 4 of them actually were not yet on any hypertensive medication during pregnancy. So because these ones, we didn't stay with them for long. I think all of them, we didn't stay with them in the fetal medicine undertaking surveillance because they already came with the deteriorated Dopplers. So we recommended the delivery. Then we had on these other 4, I think the main one has to do with the ones at the bottom there, the one with 700 grams and the one with 701 grams, who were on the pre-eclampsia medications. And these ones actually opted to have the babies delivered, even though they had that low birth weight. They opted to have because their Dopplers had deteriorated such that if the fetuses were going to stay inside, inevitably they were going to demise. So they insisted that it's better for the babies to be delivered so that they can have a fighting chance outside. And these two, they were women who had a bad obstetric history. So I think they just wanted to give an opportunity that possibly something can happen rather than just waiting for the baby to demise inside. So they opted for the elective cesarean section. But unfortunately, they were not admitted in the neonatal units, and they ended up having early neonatal demise. So I think most of the points have already been said in the previous presentation. So I think I will conclude in the interest of time with acknowledging the fetal medicine team as usual. Thank you.
Thank you, Mr. Zanga, for such an insightful presentation. I'll open up the floor for questions. I'll probably start with Dr. Ndagurwa. Dr. Ndagurwa, I know you mentioned that the mode, in terms of mode of delivery, that it is important to individualize treatment. But what I wanted to find out from you is that we have had bad outcomes following induction of labor with cytotech, especially in babies with abnormal Dopplers. Are there any contraindications to a vaginal delivery or to induction? Or as long as you have good monitoring, you can still induce? Dr. Ndagurwa?
Yes, Dr. Chamnyonga. Okay,
Yes,
so
mm.
for patients with early onset fetal growth restriction, these are patients who are less than 32 weeks, and in most of the cases, the fetal weight is less than 2.5. And so induction of labor is a no for those patients. So the problems of induction of labor in women in fetuses with abnormal Dopplers usually arise in the late onset group where she's 36 weeks, for instance, with a good weight, and the doctors will think that maybe if we induce, she will end up having a vaginal delivery. The problem is that if she's having absent end-diastolic flow or reversal of flow, that baby is sick and is already compromised. So if we then induce labor, we cannot predict when we are going to start, how the induction is going to progress, when the woman is going to get into labor, and how the labor is going to be. We are also not able to monitor those women. So if the Doppler studies are bad, it's not a good, it's a bad idea to induce labor in such patients.
Okay, thank you. Do we have any questions for Dr. Ndagurwa or Mr. Zanga? You can unmute your mics and ask your questions.
Prison management. Hello, Dr. Chamnyonga. Dr. Chamnyonga, hi.
Yes, Dr. Verenga.
Yes, so I just wanted
Please go ahead.
That, thank you so much, the fetal medicine team, for presenting this. I think to the rest of us, one of the reasons why we presented this topic and this audit of our work is to just show us that probably we can do better. When patients are scanned in the fetal medicine unit and they are flagged as absent or reverse umbilical in the ductors in the umbilical reverse or absent end-diastolic flow in the umbilical, I think let's try to operate them within the recommended time. Because one of the leading causes why babies die is one, patients are being delayed or they're being pushed away, actually, to be told they are not an emergency. Those babies are just as good as fetal distress babies. So if you are pushing them away, they are no different from somebody who is pushing away a fetal distress baby. This is why you see the increased mortality, especially those who are being induced. Was inducing a baby with absent or reverse diastolic flow, it's just like asking somebody with end-stage cardiac failure to go up a mountain and we expect them to go to the top. So I think we can do better. We can do better with these babies rather than to just let them die. We'd rather leave to the neonatal team to fight for the babies' lives than the babies to die because we've induced them when we know that they are not supposed to be induced. Especially those who are recorded as way more than 1,000. Let's give them a chance to fight for their lives. Thank you so much.
Thank you, Dr. Werenga. Do you have any questions for the presenters?
So,
So if there are no questions, I would like to thank the presenters, Dr. Ndagurwa and Mr. Zanga, for those lovely presentations. And I'll end this meeting at this stage. I don't know if there are any housekeeping issues. It seems as if there are no housekeeping issues. So I'll end this meeting. Thank you. See you next week.